Hi, I'm Dr. Joe Caprini, and I've had a lifelong interest in the diagnosis and treatment of venous disease. Venous disease is one of the most poorly understood conditions, particularly the treatment with heavy stockings and compression devices. The purpose of this video is to discuss selected aspects of compression stockings and other devices for the treatment of chronic venous disease. The video is organized in sections, including basic anatomy and physiology of the venous system as it relates to compression therapy, indications for the use of compression stockings, type of compression stockings and related devices available, and finally, the principles of measuring, fitting, application, and removal of compression stockings. The venous circulation in the legs consists of both superficial and deep venous systems. The deep veins are surrounded by muscles, and as they contract, blood is pumped out of the leg. In the upright position, the pressure in the veins of the lower extremity is equivalent to the weight of the column of blood between the foot and the heart. In the average person, this is 80 to 100 millimeters of mercury during quiet standing. When walking starts, the blood is pumped out of the leg toward the heart, and the deep venous pressure falls considerably as the muscles contract. Retrograde flow down the leg is prevented by closure of the deep venous valves. The anatomy of the leg venous system includes many surface veins which are connected to the deep system by over 150 venous branches that perforate the deep fascia surrounding the muscles. Normally, most of the blood flows from the superficial into the deep system and then up out of the leg toward the heart. Valves in these perforator veins snap shut as the pressure in the deep veins rises, so blood goes up the deep venous system out of the leg. If one or more of these valves fail to close, blood can leak out to the surface through the perforator veins, since the pressure at the surface is lower than the base deep venous pressure. Retrograde flow of blood toward the foot can also occur as a result of failure of the deep valves to close as the pressure rises due to muscular contractions during walking. This misdirected blood cannot get out of the leg unless leg elevation above the level of the heart occurs, or a compression stocking or bandage of at least 30 to 40 millimeters is applied to the leg. The valves may fail to work properly because they are damaged after a blood clot, or they may be defective on an inherited basis, or even may malfunction as a result of obesity, age, pregnancy, or other disease. Valvular incompetence is most commonly seen in the greater saphenous system. Here we see a normal valve in the groin of a cadaver as viewed from above. The vein is being perfused from below with saline solution. One can see as the flow of saline is momentarily stopped, the valve cusps come together to prevent flow backwards down the leg. When blood clots develop, they often will form behind the valve cusps, which then become damaged. With time, often a scarring process develops as a result of the previous clot, which distorts the valve and prevents normal valvular closure. We see here a damaged valve in a patient who died from cancer and months earlier had suffered a thrombosis in this leg vein. One can see the terrible destruction of the venous valve, which results in a grossly incompetent valve. If many of the smaller veins connecting the superficial and deep venous systems are malfunctioning, a rise in the leg pressure in the surface veins may develop, which produces venous congestion in the leg. Since the veins are connected to the arteries by tiny capillaries, the pressure in these capillaries rises. Normally, oxygen and nutrients delivered by the arteries pass into the tissues through the capillaries, and the white cells float along in the vessel as seen here. If the capillary pressure rises due to increased venous pressure, white cell sludging can occur. This process plugs the capillaries with activated trapped white blood cells or leukocytes that then inhibit the normal exchange of oxygen and nutrients in the leg. Activation of other blood elements can release protein-digesting enzymes, so-called proteolysis, which may result in tissue destruction. Evidence also exists that fibrin deposits forming cuffs around the capillaries also occur. If this happens, tissue fibrosis is enhanced. Furthermore, removal of metabolic waste products from the tissue cannot occur because of the capillary damage due to trapped white cells and the fibrin cuffs. This is a slow process that over time may produce leg changes as seen in this picture. If the condition is not treated, actual ulceration of the skin can occur, as seen here, due to lack of oxygen and nutrients being delivered to the tissues. This condition is known as chronic venous insufficiency, which can be the result of a previous deep vein thrombosis or blood clot, either silent or clinically evident. Most blood clots occurring after surgery, for example, do not produce leg symptoms and are so-called silent, but individuals later may turn up with chronic venous insufficiency as a result of these earlier silent clots. Varicose veins can appear as a result of these pressure changes and may be a manifestation of the chronic venous insufficiency syndrome. This syndrome is also seen in patients following leg injuries, older age patients, those with obesity, and finally those who have congestive heart failure. These problems are seen in over 15 million Americans, and 4% of the U.S. population will develop a leg ulcer at some point during their life. 11 million workdays are thought to be lost due to these leg problems in the U.S. every year, and the costs have been estimated at £2 million in the United Kingdom in a recent year. The mainstay of therapy for these conditions is compression therapy, which consists of bandages, stockings, or Circade devices applied to the leg to limit or prevent the leakage of blood into the surface venous system during calf muscle contraction. The pressure of these external devices must exceed the ambulatory deep venous pressure, so the blood has more of a tendency to go up the leg in the deep venous system toward the heart than leak out to the leg's surface. Indications for compression therapy include leg swelling, aching, tired legs, bulging varicose veins, active or healed leg ulcers, rashes, severe skin changes such as pigmentation, thickening of the skin, or a recent superficial or deep vein thrombosis. A calf-length stocking is used in about 80% of the patients, which improves the efficiency of the calf muscle pump. There are occasions, however, when compression of the entire leg is required. Most often this occurs in pregnant patients with severe varicose veins. Antiembolism hose are widely used and commonly referred to as surgical stockings. These products are widely used following surgical operations and are designed to help prevent blood from pooling in the leg when the patients are at bed rest. These stockings have an average pressure of 8 to 18 millimeters with a downward gradient from the ankle to the thigh to help promote flow of blood up out of the leg toward the heart in the bedridden patient. They do not work as well in the ambulatory patient since their pressure is not great enough to overcome the ambulatory venous pressure, particularly in patients who have venous disease of the lower extremities. Here we see a typical anti-embolism stocking in beige. They also come in white. These stockings, although not really useful for patients with venous disease, are widely used for people with swelling and after operations on the legs. The next stronger stocking is a Class 1 product which must produce between 20 and 30 millimeters of pressure at the ankle, and this is graduated downward toward the thigh. Not all brands produce the same pressure at the ankle, but they must all be within that range. The greater the pressure in a stocking, the more difficult it is to apply and remove, and the more expensive it is. It is not the intent of this video to suggest brands of stockings, but we strongly urge those who prescribe these products to get samples, to wear them, and compare them. The Class 1 stocking should not be the first choice for those with massive swelling. There is some evidence that these products are useful in those airline passengers without edema or severe venous disease in order to prevent some blood clots. They are also used by some therapists following spider vein injections. The next level of stocking is the Class II product, which delivers 30 to 40 millimeters of pressure at the ankle. One other variable in determining the ankle pressure is the size of the leg. A medium leg is usually associated with the advertised pressure, and other size legs may be associated with slightly different pressures. I personally use this class of stocking for a wide variety of mild to moderate venous disorders. It is very effective in relieving the symptoms of mild venous insufficiency and correcting mild or moderate edema. These stockings can also be used as a therapeutic test to evaluate the relationship between a person's leg symptoms and varicose veins. If the stockings improve the symptoms can be thought to be attributed to the varicose veins. They are also very useful as a dressing and support following major venous surgery or sclerotherapy. These stockings are most frequently used in a calf length model in order to improve the efficiency of the calf muscle pump. Extremely valuable during pregnancy in those with severe varicose vein disease, and also used lifelong for those with healed ulcers or deep venous insufficiency. One must be certain that the arterial circulation is adequate before using these hose, and a careful physical examination, including an ankle brachial index of greater than 0.5, should be documented. The Class III stocking is an even heavier product with a pressure of between 40 and 50 millimeters of mercury. These stockings come in several materials, and the one shown here is a heavy rubber model which will hold its compression all day long. The downside of this stocking is that it's difficult to put on, and it also doesn't breathe very well, making it not suitable for warm climates. On the other hand, this is a different material, and it can come in the same strength of stocking, i.e. 40 to 50 millimeters, but a different synthetic blend. This synthetic blend is much more attractive, as you can see. It's easier to apply and take off, but it doesn't maintain its pressure as well throughout the length of the day. So for severe venous problems, we use this heavy material, and for less severe problems, we can go to the lighter material. And I would urge a person, if they've already have someone in the lighter material stocking and they're not getting the desired effect, to go to the heavier material as a trial. Since these stockings are rubber, sometimes one has to put a nylon understocking in order to prevent allergy to the stocking when it's used every day. There is also a Velcro device available called a Circade, which consists of overlapping Velcro strips that provide a high level, over 70 to 80 millimeters of pressure when walking due to its rigid nature. The ideal part of this bandage is that it has a low resting pressure, and it can be adjusted by the patient as the day goes on. If a patient, for example, has swelling and is wearing the Circade, and the swelling goes down and the Circade gets loose, they can be tightened throughout the day to maintain a good fit and to maintain the absence of that swelling as the day wears on. One should attempt to measure for stockings in the morning when swelling is minimal. Both the circumference at the ankle and the widest part of the calf should be measured. The length for calf hose can be determined by measuring the distance between the heel and the popliteal fossa. Wrapping the swollen leg prior to measuring for a stocking is essential in order to establish a good fit for the stocking. If one fits the swollen leg with a stocking alone, it will fall down within a day or two, and the patient and the doctor both will be unhappy. Careful wrapping of the leg prior to putting on the stocking is essential in the treatment of these legs. Here we see a common method of applying a closed-toe stocking. First, it is turned out down to the heel. Next, care is taken to make sure there are no folds or wrinkles in the foot part of the stocking. It is then rocked back and forth over the foot, and here in this patient there's a large hammer toe which has to be negotiated. Then the stocking is pulled over the heel, but gloves are used to facilitate the process at this stage. The reason for this is not to tear the stocking with a fingernail or pull it with undue pressure that would shorten its life. Then the stocking can be smoothed out, including straightening out the toe. You will see here that pinching the stocking without the gloves is very difficult compared with pinching with the gloves. Removal of the stockings can be done by the reversal of this process, again with the gloves forward and aft on the foot, greatly facilitating this process. Some individuals who have strong hands without arthritis can put the stocking on without using the gloves. Here again, the stocking is rocked back and forth over the foot and pulled up over the ankle. Grabbing it on both sides and pulling at the same time little by little without overstretching the stocking, it can be fully applied without a problem. The tip of the stocking should be carefully straightened in order to avoid any pressure on the toes. Here we see an improper removal of the stocking, bunching it all up at the ankle. This is both difficult to do and is hard on the stocking and the applier and should not be done. Instead, the stocking should be folded over in a single layer down over the heel and then removal facilitated by gloves in order to avoid damage to the stocking. A closed-toe stocking can be donned using an applier as seen here. First, the stocking is placed over the applier, which has snaps at the bottom and top, which later will be removed to facilitate removal of the applier. It is important to make sure that the applier goes over the heel along with the stocking to facilitate application of the hose to this point. Then the hose can be lifted up very easily and the applier can gently be separated from the snaps as seen here and pulled out underneath the stocking. Reassembling the snaps, the applier can then be used multiple times. Removing the stocking can be facilitated using a special device which is very slippery. This device is made of sailcloth, and as you can see, you fasten a Velcro strap first. It is important to pull the stocking over the heel, then with a scraping motion, the stocking can very easily be removed from the leg. Open-toe stockings may be applied with the use of a large slipper. First, place the device inside the stocking. Shown here is a heavy rubber stocking, which is normally difficult to put on. Next, the stocking and the slipper are advanced over the heel with pushing motions as seen here. The heel can be adjusted also by sliding back and forth over the rubber pad. It is then easy to remove the slipper following lifting the stocking just by standing on the stocking tip as shown here. Heavy rubber stockings are an advantage because they hold their pressure on the leg the best during the entire day. They are, however, difficult to remove. This removal can be facilitated with a removal device that is placed over the stocking and then placed over the heel. It is important to use scraping motions to remove the stocking and applier. This method is often used instead of manually removing these very heavy hose. Here we see another slipper made of the common material used to wrap houses for insulation. The method of application is the same. It is important to make sure that part of the slipper gets over the heel to facilitate the stocking going over this heel. Again, one can adjust the heel by pressure on the rubber pad with a foot. This slipper, which is made of slippery material, is easily removed, which is the real advantage of this material. Final adjustments in the stocking fit can be made using the rubber pad. Here is another method for hands-free application of a compression stocking. A combination of foot rocking and pulling the stocking applicator greatly facilitates application of the hose. This applicator can be used for both closed and open-toe stockings. Removal of the hose can also be accomplished using the applicator and the hands-free technique as seen here. In cases where the patient is unable to bend easily, the use of a chair or bench facilitates application of the compression stocking. In patients where bending may be a problem, the use of a chair or bench is extremely valuable for removing the compression stockings. This scene shows a young woman who is 9 months pregnant and cannot bend over well, applying a heavy rubber stocking using an applier. A rubber pad placed on the floor facilitates the application process. One needs to push forward carefully with the heel so the stocking goes up over the heel. It is important that the applier be long enough to accomplish this purpose. Then, as she shows here, one can pull the stocking up the leg very easily without resistance. I would have preferred to see her use rubber gloves, which would have made this maneuver even easier. Removal of the applier can be done simply by stepping on it with the other foot and gently pulling out the foot. These stockings are very difficult to remove, but using the table and a remover, this process is greatly simplified. It is important to pull the remover all the way up the leg and then to fold down the stocking far enough so that the stocking end goes over the heel. Once this is accomplished, a simple scraping motion can be used to remove easily this stocking in about 15 to 20 seconds. A variety of devices are available to treat leg disorders related to venous disease. Using a method in a particular patient that is associated with the greatest compliance is the key to successful management. No one device is suitable for everyone. The approach to each patient must be tailored to a variety of pathologic, social, economic, and personal variables. Finally, I would like to thank you all for watching this video, and hopefully it will make the care of patients with severe venous disease in your practice much easier.